Good morning, everyone. So, with your permission, we'll start. So, a warm welcome to everyone here, and also a warm welcome to all of those who are joining on the webcast. We're also having a live webcast of this entire event. Again, welcome to Human-Centered Approaches to HIV Epidemic Control in India, National Symposium on Learnings from Accelerate. So first of all, I would like to clarify also that this is a symposium consolidating a lot of the experience and implementation that we have actually been doing over the last 3 years. It's not a closing of project dissemination or to that effect. It's more so to seek your guidance and to have a consultative process going forward over the next couple of years for Accelerate as well. So again, on behalf of Usaid and PEPFAR and the Accelerate program, which is implemented by the Johns Hopkins University School of Medicine, which works very closely with NACO under the policy guidance and leadership of NACO, as well as the state control societies, I welcome you. Also, Accelerate as an entity represents a collective of many organizations and people. Our partners, YRG Care, are implementers on the ground. We also have the Fenway Institute, as well as the Blue Lotus Advisory, which are partners with Accelerate. And I'm Aditya. I work as the Deputy Chief of Party and Executive Director for Accelerate. Now, I think I would just like to share a little bit about human-centered design and human-centered approaches to health. There are, of course, several papers, presentations, and a lot that has been done, but I'd like to maybe summarize it in the words of one of the founding fathers of the Johns Hopkins University School of Medicine, and that was Sir William Osler. So Sir William Osler summarized it, I guess, in the most understandable way, saying that a good doctor, and I'll paraphrase, a good doctor or a good health service provider is someone who takes care of the disease, whereas a great doctor or a great service provider is someone who treats or takes care of the person with the disease. So that's essentially the spirit that we've tried to embody within Accelerate as well. And as all of you would have received the packages when you registered, and there are several technical briefs and documents within that, which reflects these last 3 years. But that is also how we have planned the agenda. So just to give you a rough sense of what we are going to be doing today. So after the inaugural session, we will be going into details of various technical aspects implemented by Accelerate. So we'll be talking about comprehensive service delivery models, which includes our work with transgender people, as well as adolescents and integrated centers for PLHIV. We'll also be we will also be having specific sessions on prevention and testing, and then care support and treatment, which will also include our work around children living with HIV through the Orphans and Vulnerable Children program. Throughout the day, we're also looking at releasing and announcing a few new things. So please keep your antennas up for that. So there are a few interesting things happening, paving the way forward for Accelerate. So that will be also built into the agenda. Apart from what you have as packages, there is several content and materials on display, as well as available as online content and in hard copy. So it's all around you. But if any questions at all, please feel free to reach out to me or any of my team members. So again, today we are extremely fortunate to have the leadership at NACO. Shri Alok Saxena ji, thank you so much for being here, as well as several HODs from NACO and as well from Usaid. So thank you so much for being here. Also, thank you to the community members and all our partner organizations and the Accelerate team who have made it here today. Before we start with the inaugural, I think I just like to invite our speakers for the inaugural session on the dais. So first up, I'd like to invite Ms. Sukhwinder Kaur. Ms. Sukhwinder Kaur works as a project management specialist for strategic information with Usaid. She's also the focal point for the Accelerate program within Usaid India. Sukhwinder, please. A big hand for Sukhwinder, please. Up next, I'd invite Dr. Sunil Solomon. Dr. Sunil Solomon is an associate professor with the Johns Hopkins University School of Medicine in the Department of Infectious Diseases. He's also the chief of party for the Accelerate program and divides his time between India and the US. Dr. Sunil, please could you come to the dais? Up next, I'd invite Ms. Nidhi Kesarwani, the director with NACO. A warm welcome to Ms. Nidhi Kesarwani. I will invite Ms. Deepika Joshi, who is the chief of the HIV/AIDS division in the Usaid India, currently leading the Usaid team on HIV work. Big hand for Deepika Joshi, please. Ms. Sangeeta Patel, who's director with the health office in Usaid, is joining us shortly. She'll be on the panel as well. For now, I will request also, I just want to share that we are fortunate to have the additional secretary in Ministry of Health and Family Welfare, Madam Hikali Zimomi here as well. Ma'am, with your permission, if you could join us as well, please, on the dais. And of course, I would extend my welcome and also request Shri Alok Saxena ji, Additional Secretary and Director General NACO, to join us. Big hand for Alok Saxena ji, please. So I will now invite our first speaker to join us for a short presentation. Sukhwinder, over to you.
Thank you, Rishi. And thank you, Aditya. So good morning, everyone. Sorry, I have got a bad throat, so you have to just excuse me for that. So respected sir, ma'am, the Usaid colleagues, I'm very, today I was feeling very, very happy. Aditya said that we all are working together. I was very happy to see that on a Saturday, we all were able to join. So first of all, thank you and a big applaud for all of you that besides being Saturday, you were able to join us. So very quickly, I'll be covering a little bit about like what PEPFAR journey so far and all the flagship programs which we have like Accelerate, linkages, all what we have done and how we have, rolled out, scaled up, and ultimately given it to NACO or the state AIDS control societies for the scale-ups. So, so as you know, this is a PEPFAR has been a valued partner in the fight against HIV/AIDS since 2003. And the program has evolved because this PEPFAR is a US President's emergency plan for AIDS relief. But during the years, it has evolved from the emergency response initiative, which was just initiated in the 15 countries, but now it's being seen as a significant player in the global AIDS policy arena, which is currently running in more than 50 countries. So PEPFAR India focuses on providing technical support along the prevention to care and treatment continuum and works very closely with Government of India, National AIDS Control Organization, as well as at the state level, providing assistance under the cluster strategies, while accelerating core intervention from the epidemic control with equitable access, demonstrating scalable models to effectively and efficiently provide HIV services to the key population, their partners, and families. I would also like to highlight that PEPFAR's unprecedented achievement has progressed in spite of devastating impact of COVID-19 across the world and India. Now, almost after 20 years of its creation, PEPFAR is at a turning point. We are reimagining, we are revamping PEPFAR this is attributed to the shifts in the global or the country, due to the COVIDs under the new, and this almost 20 years, why we are revamping when we were also going through that, what is the need of revamping? Because, after COVID, the lot has changed at the country level, at the subnational level. Also we are having a new administrator at the Office of Global AIDS Coordinator. So when we say that reimagining of PEPFAR globally, that strives to both focused uh, and bold decision, because the strategic direction is prioritizing the area where PEPFAR can reimagine, revamp the responses to uniquely deliver the result, and also at the same time, double the gains. So reimagining, when we are saying this will be around the 3 Ps: program, people, and partnerships. However, the guiding principle remains the respect against equity, accountability, impact, and sustained engagement. And with the 5 strong enabling pillars, which is also highlighted over here under the new revamp strategy, sustaining the response, leveraging the assets, impactful partnerships, closing the gaps around the vulnerable population, and follow the science to bend the curve on the new infections. The reimaging is also around deep engagement with the strategic thinking of our global partners, UNAIDS, WHO, and global funds, percolating down to the country level. At India level also, PEPFAR India will continue to maximize the synergies by building the healthier and more equitable environment, working with Government of India, global fund partners, and with the communities. Now, with this slide, I just want to highlight that with the evolution of, because PEPFAR India work in tandem with the National AIDS Control Program towards the common goal of ending the AIDS epidemic as a public health threat by 2030. So with the evolution and progress of NACP from NACP 1 to NACP 5, which is from isolated activities to the mature strategies with the development of strong mechanism, our yearly country operational plans, because at PEPFAR India, we go by the country operational plans and the regional operational plans. Both of our sister agencies like Usaid and CDC, we work at the cluster level on a year-on-year basis strategies. So along with the point is that along with the NACP evolution, our country and regional operational plans were also in line of NACP, focusing around optimizing the impact of resources in achieving the epidemic control while adopting the cluster strategy. So right from the centered, client-centered towards person-centered to the people-centered orientation, quality assurance of HIV testing, promoting innovative strategies, meeting all the 95 through intensive case findings, testing and treat implementation, providing TA for development and implementation of viral testing guidelines, strengthening the lab capacity, leveraging the OVC control program, TB HIV as a single window, epidemic control among the PIVOTs at the Northeast, crosswalk the community-led monitoring, and also continue to engage KPs to lead and develop the integrated strategy. So PEPFAR India, as I've just told that both the sister agencies, they work hand in hand for the common goal along with the Government of India at the national and the subnational level. So the PEPFAR India program through CDC and USAID has been successful in leveraging its investment to develop innovative approaches for HIV response in India. So which means that in order to implement our country operational plans and the regional operational plans, strategies, PEPFAR, USAID, and CDC partner work from prevention to care continuum to bridge the above site and at site work to magnify the impact. So here in this slide, we have just tried to write down all the partners at the PEPFAR level who had made contribution on, who are working on the cluster-based strategies, right from the prevention to the continuum care. For ROP22, just want to say that this is currently started from October 22 to September 23 that we have already started with, and these are the partners whom we are working with, USAID and CDC. So, so for this slide, this is just giving the historic overview of the USAID portfolio in India. So for this slide, I would really like to say with the sincere thanks to NACO, SACS, community partners, CSO, that we are very proud of what we have achieved so far with our so many flagship projects like Accelerate. I'll not name out any single project, but would rather to highlight that capitalizing uh, on the groundwork which is established by many of our projects has a significant impact at the district and the community level in efficiently supporting and managing the subnational HIV/AIDS program, thereby enhancing the overall program quality. Through these projects, we have been able to clearly show that how innovation through central and local leadership support, technical assistance, which is delivered in timely and efficient manner with the robust on-field processes can be critical for the outcome of the programs in design, implementation, and better follow-up at the district and at the state and the sub-district level. Again, under the guidance of NACO, so we are talking about all the flagship projects which we have done based on the cluster-based strategy. So again, thanks to NACO and the SACS and all the community partners under the leadership of NACO, the innovation under USAID PEPFAR project were path-breaking for future interventions, such as this great grand challenge. This grand challenge happened for the first time in the HIV under the linkage projects by the FHI 360, which was hosted the Rethink HIV Grand Challenge. It was one of the priorities of the project, which was done in collaboration with NACO, Ministry of Health and Family Welfare, Government of India, and USAID. The unique initiative which was promoted under the project led us to reach at-risk population in the virtual space. There were over a pool of 64 applicants who applied under this grand challenge, and three of them were selected. The seed money was provided for 6 months. And as a result of that, the pilot were able to reach to 3 lakh people online with the information on prevention, testing, and treatment. So it was a result of this grand challenge, which was done under the USAID PEPFAR. The innovation learnings, along with the Yes for Me, I think many of us, we know about the Yes for Me platform, which is now the Safe Zindagi. My fellow colleagues will cover during the day. So, the Yes for Me were path bearers for the future virtual interventions, which is being implemented all over the country through the Global Fund grant support now. So Yes for Me, as I just said, is now enhanced as a Safe Zindagi. So with this, I just end my presentation over here and wish all the great success to the team for the rest of the day's proceedings. Thank you. Thank you.
Thank you. Thank you, Sukhwinder. So also want to share that today is National Teaching Day. It is also something that celebrates the birth anniversary of our former president, Shri Abdul Kalam ji. So on that occasion, the gifts that we are giving are the tokens of appreciation, are not the usual green welcomes. We are providing some books and related to the theme of National Teaching Day. So again, I'd request, thank you, Sukhwinder, for your talk. I will request Dr. Manish Bamrotia to please come over and felicitate Sukhwinder Kaur. Big hand for Sukhwinder. Thank you. Next, we have a presentation by Dr. Sunil Solomon, who is the Chief of Party for Accelerate. I again request to dim the lights near the presentation, please. Yeah. Over to Dr. Sunil.
Thank you, Aditya. Good morning, everyone. Before I start, I wanted to thank Shri Alok Saxena and Madam Hekali and dignitaries on the dais, off the dais, and all my friends, community, other implementation partners. Thank you for coming here today. Before I actually talk about the achievements, I do want to acknowledge that it is a Saturday, you're all here. I don't expect you to stay the whole day, so that's why we figured we'll do like a quick recap of whatever we've done in Accelerate in the next 15 minutes. So if you decide to leave, you still have a fair sense of what we've done. But again, just to be clear, these achievements would not have been possible with a lot of support we've had. And I want to start by acknowledging the Usaid leadership, starting with Xerxes Sidhwa and Maria too, on to Dr. Ms. Sangeeta Patel, Vandana Stapleton, our AORs over time, starting with Jeeban Baisha to Dr. Sangeeta Kaur to Sukhwinder and Rita Prasad, who really have been instrumental in helping us move forward. All the respective state AIDS control societies, because again, we needed to work with the communities and the states to make this happen. And I think it's sort of a bittersweet day because it is probably going to be our last big meeting with Shri Alok Saxena, who has been instrumental in our program and been working very closely with us. But it's also, like Shakespeare says, the show must go on. And I'm glad that Ms. Hekali was also able to join. And I'm hoping that we are able to figure out what the next steps are and how we take this forward. But I think the two most important people without which this would not have been possible are the community members, like the PLHIV community, the key population communities, because we really got to where we are today, despite COVID, because of their support. And the last thing, and probably the most important thing, the reason we're going to show you all these achievements is because of our team, the Accelerate family. I'm just standing here presenting data, but I'm not responsible for most of this. It's the field team. It's like the index testing coordinators. It's the treatment buddies. It's the staff at the Mitra clinics. They really are the champions. Unfortunately, we can't get everybody on the stage, and so I'm here representing everyone. So that being said, over the next 15 minutes, I'll try and take you through like a very quick snapshot of different achievements, different programs we've accomplished over Accelerate in the past 3 years, and what our direction is and what our strategy is going forward. So for those of you who are not aware, Accelerate is a Usaid PEPFAR funded program. We started in 2019. We run through September 30th, 2024. The objective really was to implement, evaluate, and transition promising, sustainable, and novel methods of HIV prevention, testing, and treatment, guided really by evidence-based data. Right, so that's where Accelerate really started. We have 3 major sub-partners and tons of community partners with YR Gaitonde, the Blue Latest Advisory, and the Fenway Institute in Baltimore. We also have a virtual platform called SafeZindagi.in. So the states that I have listed on this map are the states where we're actually doing work at the field level. So it's like the direct service delivery sites, but we actually work with NACO across the country on several other issues. The one thing I also want to highlight on this slide is, though we are working in these districts, we were able to get a cost-share commitment from the Elton John AIDS Foundation because of this, and we were actually able to expand the learnings from these PEPFAR clusters into UP and Delhi, where I'm sure many of you are aware, HIV incidence is extremely high, especially among people who inject drugs in the trans community, and not much is being done. So it is an opportunity where you can leverage one program and seek donations from other programs to really grow the program. So I want to start by going through the different steps. And I think the most important thing, because this is something I've been dinned into my head from the time I was a child, is prevention is better than cure. And unfortunately, in HIV, we don't have too many preventive tools. And the one tool we do have is pre-risk exposure prophylaxis. So we did work very closely with the National AIDS Control Organization, the other implementing partners, helped out with the different consultations. Manish Bamrotia from our team was very instrumental in drafting the first guidelines, which we got feedback from the different implementing partners, revised it, and we actually had this released in 2019 in December on World AIDS Day. But I do want to highlight the one thing we did in parallel was it wasn't enough just to have a guideline, but we also built a training curriculum, which is completely free. It's online. And so if anybody wants to learn about PrEP, they can go complete this course. It teaches you from A to Z on what are the before you start PrEP, what do you look for? When you start PrEP, what do you look for? What are the different steps in counseling? Who's eligible? Plus follow-up. What are the different monitoring tests you do? How do you stop someone on PrEP? And it's very aligned with the National AIDS guidelines itself. And so it's something that came out in parallel. So in case you want to build capacity, whether it's in the public sector or private sector, there is a free course that is available that we've built. So this course was actually built by people from the Harvard and the Fenway Institute. So it really is from a reputable institution and not something we put together overnight. And just to give you a sense, so we've been rolling out PrEP through our online platform, which is safezindagi.com. So it's operational in about 40 cities across India. We've registered about 752 people, out of which 578 people initiated PrEP, and about 430 are still on PrEP. So they are going to talk more about this in detail in the other sessions, but just to give you a sense that it is possible, and while there is no public sector rollout yet, there is a big demand for PrEP, especially among these populations in virtual spaces, because they do have income. And so it's something to think about. Like, do we really need a completely free model? Can we look at a cost subsidized model, or can you have all these different kinds of models? I think that's something that really has come out from this exercise. And most of the people who have dropped off on PrEP is because they either stopped engaging in risky behaviors, or it's zero discordant couples, and so there's no reason to continue PrEP in those populations. The other thing I do want to highlight was yesterday we actually started a rollout of PrEP from our Mitra clinics, where we got a donation from the John C. Martin Foundation. For those of you who are not aware, John C. Martin was the CEO of Gilead. So he was the person who was responsible for Truvada, who was responsible for PrEP, who was also responsible for the single tablet regimens. So it was very fitting that his foundation gave us a donation of $100,000, which allows us to provide PrEP for about 1,000 trans community members across the different Mitra clinics in India. So we will be looking at it very closely, and I'm hoping that can help inform policy and help inform how do you actually roll out PrEP free of cost in different settings, whether it's public sector or private sector or other places across the country. And speaking of the Mitra clinics, I think this is, again, completely because of Simran. So thank you, Simran, for pushing her way and making this happen. I just had to sit back and let her go right through it. And so the Mitra clinics really is this comprehensive one-stop model that we established. We registered about 2,500 clients, and about 96% of them were assigned male sex at birth. So it's generally trans women who are, but we do have a few trans men who are also coming to these clinics. I think the one thing I do want to point out is the way we designed these Mitra clinics. It wasn't like an HIV-focused clinic, but we did a lot of focus groups with the communities to understand what they really wanted, right? And laser therapy, skin whitening were really the services that the community wanted and not HIV services. And so we said, well, if that's what they want, then that's what we should give them. And so when they come into the clinics, we really say, okay, you're here for your laser therapy, but while you're waiting, do you want to get screened for HIV? Do you want to get screened for viral hepatitis? So it really is integrating all these different health systems together. The other thing we also found that the community really appreciated was the access to the things like the transgender certificate and other social entitlements, which really need a computer and someone who's computer savvy to help you out with these things. And so when I was in the Mitra clinic in Hyderabad, some of the clients told me that was really the service they appreciated. But what it really shows you is we need to stop thinking about a disease focus and start really transitioning to the person focus, which Aditya talked about, right? And start thinking about non-HIV entry points to HIV care, and start thinking about integrating across the different ministries, whether it's the Ministry of Social Justice, whether it's the Ministry of Health and Family Welfare, or whoever it is, but really treating that individual as a whole. And what we also found within these clinics, the HIV prevalence was about 7%. We diagnosed about 31 new people in these clinics, all of whom were initiated on antiretroviral therapy at the public sector facilities. So there really was that good feedback mechanism. And again, 7%, for those of you who are not aware, is about double of what the estimate for HIV is among the trans community in India. So you really were tapping into this high-risk burden community. And the other thing we wanted to point out was about 3/4 of these people self-reported. Like, there's no way for us to verify, but they told us that they'd never been to a TI before, but they were coming here for all the other services. So it really does highlight that point of how do we actually cater to these populations who we are not reaching through the program. And it seems like we need to start thinking outside the HIV box. So we can try to prevent, but we know some people are going to get infected. So the next step is once we really have to think about testing, right? How do you improve access to HIV testing? So the first thing, and probably the easiest thing to do, is index testing. I think most of you understand what index testing is. So you take an HIV positive client and you ask them, do you have any sexual partners? Do you have any injection partners? Do you have any biological children? Do you have a spouse? So the government already does a lot of spousal testing, but some of these ICTCs are overstaffed, so it is challenging to reach out to all the sexual partners, make sure you find all these sexual partners, bring them back in for testing. So that's really where we fill the gap, is looking more at the sexual partners and the injection partners rather than looking at the spousal partners, which is being done very successfully by the government program itself. So between September 2019 and September 2022, despite COVID, we diagnosed about 10,000 new infections. The HIV prevalence was about 19% among, which is 1 in 5 contacts whom we were eliciting was testing positive for HIV, and about 87% of them were initiated on antiretroviral therapy. So that deficit is because this data is very current, and there's generally a delay from the time you find someone and link them to ART. So if you cut the data at a particular time point, it's closer to 90-95% who are being linked to antiretroviral therapy. But again, when you add human resources, the big question is it sustainable? And so I know this slide is very busy, but what I wanted to show you is like Pune and Thane were the only 2 districts where we worked over 2 different drop years. So from 19 all the way to 2021 and right through COVID. And so it actually gives a good opportunity to look at the cost, like how much does it cost to find one particular infection? And what you can see is between the year 1 and year 2, the case detection went up and the cost started dropping, right? And the same thing happened even for people who are being initiated on antiretroviral therapy. It went up by almost 149% in Pune, and the cost of the program dropped by about 68%. Right, so the final cost is about $187 to find one person and link them to antiretroviral therapy is much cheaper than what it actually costs in generalized epidemics in sub-Saharan Africa. Right, so you're working in a city, in a setting like India with a prevalence of 0.22%, and you're actually ending up being more efficient than working in a country where the prevalence is 20%. Right, so it really does show the value of index testing, and it's something we should think about. Is I know adding costs is always a big burden on the program, but it's thinking about reallocating costs. Is there something I can move from there to here, because it actually ends up being a lot more cost efficient? So the next strategy I want to talk about is, so there are people who go to the facilities, and then you have a lot of people who don't go to the facilities. So for these populations, we use something called the social network strategy, which doesn't really focus only on the positives, but it looks at networks. So it looks at positives and negatives to positives and negatives. It just keeps going. Between October 21 and September 2022, we screened about 5,600 people. Again, what I want to highlight is a lot of these people whom you are reaching through these social network strategies and other things that don't rely on facilities or the TIs, you actually end up reaching a lot of populations. Again, this cannot be verified. All this is self-report, but they do say that they've never been engaged with the HIV program. Overall, HIV prevalence was about 474, but we did diagnose about 103 new people out of this 5596. And we also identified 59 people who were not on antiretroviral therapy, whom we were able to link to the program. And about a third of the entire sample self-reported that they've never been to a TI program. So again, it does show that index testing reaches the populations that come to the facilities. These social network strategies and respondent-driven sampling strategies reach populations that don't come into facilities. But then we moved to the more complicated thing about these virtual places, right? So that's where we had the fortune of inheriting from linkages as the Yes for Me platform, which we've transitioned to Save Zindagi. So even in the virtual spaces, there are a subset of people who will come from the virtual space to an actual physical lab to go and get tested for HIV. And that's why the Save Zindagi platform actually works. So we've screened about 10,000 individuals, and we've identified about 700 new HIV infections through this platform. Our positivity is about 7%, and confirmatory testing was done for most of them. We have about 6% confirmed positive, and almost 85% of those whom we've confirmed positive have been initiated on antiretroviral therapy. So the one thing I do want to point out is this is a virtual platform. The general population prevalence is about 0.22%. And we're hitting a prevalence of 6%, right? So it's reaching a population that is not being reached by the government programs, right? Because they are really hanging out in these virtual spaces like Grindr, Tinder. And what was even more alarming was 73% of these people had never been tested for HIV before. Again, all this is self-report. It's like a full disclosure. I'm going to stop saying that because it's going to start sounding repetitive. But what we also did is we worked with NACO to develop a white paper on the strategy. And I know NetReach and there are other programs that are also going on. So this is again the cover of the white paper that we designed with a lot of feedback from Ms. Vinita Verma from NACO and with the DG as well. Thank you, sir, for all your feedback. And the last population is, so even when you're in those virtual spaces, there are some people whom you can't take from those virtual spaces to the physical spaces. And that's what we call virtual to, or that should be virtual to, okay, anyway, this is a virtual to virtual, right? And so what we actually did here was we used HIV self-testing, right? And so what we did was people who wanted a test and did not want to go to a physical space, we sent them HIV self-test kits. And for those of you who are not aware of the platform, we have like a whole demand generation. We have a lot of education happening on there. We have a group of virtual outreach workers who sit in like a call center and they work with all these people. And most of this happens over WhatsApp, right? And I think most of you in this room are probably on WhatsApp at this point in time, but it's exactly how the program works, right? The whole entire system of engaging them, finding them a place to get tested, making sure they get tested, making sure they get linked, everything happens on WhatsApp. And what we found is with HIV self-testing, we were still reaching about 6% who were screening positive, about 3% of them were confirmed positive. So the real big challenge with these virtual platforms in that virtual to virtual space is with like, how do you actually do a confirmatory testing without bringing them to a physical space? Because there's a reason they don't want to come to a physical space. And so we really need to start thinking outside the box and how do we actually just keep the whole thing running in the virtual space. And the key lessons were the virtual outreach workers critical to success. And the one feedback we did get was like all these HIV self-testing materials really need to be tailored to the communities in terms of language, culture, the way the pictures look. And so that's what we actually got back from the different clients who use the self-testing program. We've also drafted an HIV self-testing white paper in collaboration with the National AIDS Control Organization. A lot of the feedback has been incorporated, and I'm hoping it will be released shortly. And once we test people, we need to treat them. And so in terms of treatment, I think the government is doing a fabulous job. And I think one thing, which I think Mr. Naveen Kumar was also talking to me earlier today, was like the literacy really is bad. People don't know about what they're taking, how to take them, and especially going down even to the doctors. Like sometimes the messages don't go from the center all the way down to the state. So we built a lot of job aids and treatment literacy material. Because when I've been seeing patients living with HIV since like 2002, 2003, makes me look really old, but I have been seeing people for almost 20 years living with HIV. And the one thing I realized was talking to them was very important because many of them just feel alone. They're like, is there no one else like me? Because especially if you're thinking about HIV in India in 2002 or in the 90s, there really was a big stigma attached to it. And so it became really important that communication and building that treatment literacy material to talk to these individuals who are getting on antiretroviral therapy and reminding them not to forget, telling them stories about how do you remember, telling them about watches, alarms on cell phones and different things. Technology has evolved, some of us haven't, but I think that's the nature of the game. We also have some new job aids that we have developed, which we will be releasing later today, especially for the staff at the different ART centers where we're currently working at. The other thing that we did work with the National AIDS Control Organization is the verbal autopsy program, where we looked at the verbal autopsy for about 1,001 clients, ending at March 2020. So that's when their actual reported deaths were. We went back and tried to ascertain what was the cause of death. And I think what is really striking is about 77% of these deaths are still related to HIV-related OIs or HIV and TB. About 15% of these deaths are non-communicable diseases, especially cancers. And I think what is striking again, Manish will talk a lot more about this in the afternoon in detail, is in cancer, women have a much higher burden of cancer compared to men, right? So which brings us back to that whole thing is like, if we can do a pap smear in the gynecology ward, the government medical hospitals, is there some way we can start integrating pap smears and breast exams into the ART centers, especially for women as they age, because there is this high burden of cervical and breast cancer, especially among women in the country. The last thing I want to talk about in treatment is a TAL, which is an integrated health model. I think many of you know in India, about 80% of the population seek healthcare in the private sector, which is very different from the HIV program, where almost 95% are in the public sector, right? But still, there is a burden about 10 to 15%, which we estimate go to the private sector for antiretroviral therapy. When I spoke to Manoj from NCPI earlier on when we started the program, he said, well, we have like the free model and we have the extremely expensive model. We don't have an in-between model, like a cost subsidized model. And that's where this TAL model really fits in. Our vision was to develop a one-stop shop And we were delayed by COVID, but I'm hoping that Manoj has promised me by the end of September 2023, it will be self-sustainable. Because you are able to generate some profits from the sale of the medicine, which can actually go back to supporting that staff. So we provided that initial infrastructure, but the whole model is run by the NCPI, which is people living with HIV for HIV. We registered about 674 clients. About 96% of the clients we're testing at these centers are biologically suppressed. There's also a Link ART center, which played a very big role during COVID and provided antiretroviral therapy to 800 people. And Manoj is, again, very instrumental in getting access to COVID vaccination. So again, it really is becoming that whole person one-stop shop, which really seems to be what the future of HIV programming should be. And once we start treating them, so I always tell people, starting people on treatment is the easiest thing to do. Keeping them on treatment, not so easy. Right? So I think that's where the retention and the efforts of retention of the program actually fit in. So our primary retention efforts are the treatment buddies or the outreach workers, and working very closely with Project Vihan from the Global Fund funded program. So the treatment buddies, again, are something that's in the operational guidelines. What we really do is help make it happen. Manish and his CST team have really been doing a lot of training with these different groups to tell them how do you track clients, when to call them, how do you go find them, bring them back into the program. So we have data for about 7 quarters, and you can see, like, right now we take care of about 109,000 people living with HIV across the 7 cluster districts that we're currently working in. But the 2 things I do want to point out is that's the number of new people who were initiated on antiretroviral therapy. So it's somewhere between 2,000 and 2,500 every quarter across these 7 different districts. And that big dips that you see in those 2 different places, so April to June 2021 is when we had that massive Delta surge in India where everything dropped. And if you look at like the overall gains at these antiretroviral therapy centers, we really have picked up from where we started. We're adding about 3,000 clients, 2,500 clients every month into the program across these 7 districts where we're currently working. Again, complete testament to the great work by the Vihan team and the treatment buddies at the field level. The other thing we actually did was during the first wave of COVID, I think Partha and Christian and the team are very instrumental in making this happen in Telangana. So we started in Telangana on April 2nd of 2020, right after COVID happened. And the first thing they told us, like, we need to get medicines for these populations. What can we do? So within 2 weeks, we were able to mobilize it. And we made about 17,500 deliveries of medicines to people's houses, learned a lot of things along the way. Things that we take for granted are not really, should be taken for granted. For example, some of the patients actually told us, don't give us multi-month dispensation. Give us 1 pill bottle at a time because we don't have places to hide 3 bottles of pills. A lot of other patients, a lot of other people told us, don't come to our houses. My brother doesn't know, my mother doesn't know, meet us at this bus stop, meet us somewhere else. So it really was a learning experience, and we were fortunate enough to turn that into a field notes with the Telangana SACS leadership, the NACO leadership, led by Partha, and so it really is being disseminated across the country and how, across the world, on how India actually adapted, and these are models that you could use in other countries globally as well. Self-verified adherence is, again, something that we did get from Linkages program, but we did modify it, and we built in a lot of support from the 1097, which is the NACO helpline. Because again, like I said, sustainability really is the goal. And when NACO has a helpline, we said we need to build into that helpline. So the way self-verified adherence works is someone takes a tablet, they give a missed call to a number, and then it marks off as having taken the tablet. And if they don't call the number, then someone from the 1097 helpline calls them and checks, have you taken the medicine or not? And if they say, oh, yes, I took the medicine, but I forgot, then they check off the box. If they say, no, I didn't take the medicine, I forgot, then they just mark it as an X. And if they miss like 3 days, only then the outreach workers actually track them. So our first line of defense is always the 1097, leveraging existing resources wherever they are. So we have about 7,000 clients who have been enrolled in the SVA program. The adherence reported is about 86%. And about 98% of those who have undergone viral load testing are virologically suppressed. So we are looking at comparing this to the populations who have not been on self-verified adherence versus other antiretroviral therapy centers where we don't have the SVA program to see, is SVA actually making the difference, or is the SVA just like this gadget that's in there, but patients really are very adherent to their medications. And the other thing we did start through this program are the adolescent-friendly health centers, again, spearheaded by Aditya and Subhash, who really made this happen. So I think many of you do realize that children living with HIV are also children. and we generally tend to think of them like, oh, you have HIV, you need to treat your HIV and not worry about anything else. So we started these adolescent-friendly health centers. The first clinic was in Imphal, Manipur. And I think what was really heartening was there really wasn't much talk about HIV. It was a lot about music classes and martial arts and everything else. And that's what really drew these kids into these centers. And when they were in there, we spoke to them again about importance of adherence and how do you actually keep it going. The other thing I do want to point out with the adolescent-friendly health centers is we were able to partner with Paul Newman's foundation. I think many of you know Paul Newman, the actor. So he has a foundation called Serious Fun Children's Network. And his belief was every child is entitled to fun, regardless of how sick you are. And so we were able to pull these little weekend classes from the Serious Fun Children's Network. So it's done over 5 weeks in these different AFHCs we have. And what it actually does is it teaches you through game resilience. It teaches you about adherence. It teaches you about antiretroviral therapy. It teaches you about coping, but you don't really realize you're being taught, right? Because you're always playing games along the way, but you're actually learning some life lessons as you're playing these games. And this is something that Paul Newman was like a big fan of. And so we have been able to adapt it into the Indian setting. And what we have seen is like among the children who are coming to these adolescent-friendly health centers, we are seeing like a viral suppression about 84%. I think compared to the children who are not coming to these centers, especially when we started the program, the viral suppression rates were about 55 to 65%. So there really is like an impact. Again, I can't attribute the whole thing to the center because things have changed temporality, but it definitely does show that there is a value because even if it has nothing to do with the viral suppression, I think smiles on kids' faces definitely has a lot of value in most of our lives. The other thing we also learned from COVID was we said, okay, we're doing all these different things, but what else can we do? And so when we talked to the different communities, like what really came out was we were very HIV focused in our COVID response, but HIV really wasn't their need. Right? So the children were telling us, you're coming home and giving us antiretroviral therapy. Who is going to give me food? And the trans community, I think Simran told me like a lot of her friends from the community were essentially saying, well, you're giving us antiretroviral therapy and this, but we have lost our livelihood. We have no money. Like how are we actually going to sustain ourselves through COVID? And I think that's the one thing we all forgot during COVID is like, we forgot they were all people. I was like, okay, let's manage their HIV, let's manage their TB, let's manage the viral hepatitis without thinking about what would we want when the whole world was shut down? We would want food, we would want shelter, we would want some access to money. So fortunately, we were actually able to raise about $100,000 from different donors in the US, and we supported about 3,000 families of kids for about 3 months with food. We were able to provide, I think, economic support to about 500 trans women during that period. So it actually ends up showing that we really need to start taking that person-centric approach, and that's something I think where the PEPFAR ideology is also shifting to. So that really highlights like all the different activities that we're doing. And the one thing I do want to say is like, we're not doing them in silo, right? They each feed into the other. So for example, the Mitra Clinic goes from prevention to testing to treatment to retention. And everything really does feed into other, and you cannot do these programs in silo. And we are fortunate enough to get the funding from Usaid and PEPFAR to actually work across the entire continuum, which really does allow us to follow people from prevention to retention. But before I end, I want to end with the last thing that I want to highlight is, so we did build like the induction course and the training modules for capacity building of the strategic leadership at National AIDS Control Organization. So this is something that Ms. Aarti Ahuja and Shri Alok Saxena had asked us to do. So the course is done. And this is what the certificate is. So what this course is really designed to do is it's for program leadership at NACO and at SACS to walk them through the entire HIV program from the prevention to the basic services division, to the CSC division, admin, and even at the district level, right? So if you have a question saying, okay, this is going wrong, who do I contact? So this course is supposed to give you a good outline of where can you go, right? And so this course should be up and running as soon as we can get the clearance from the server. So in terms of the future, I think the whole person approach, we've been talking about it the whole time. I think we always think about prevention or testing or treatment, but I think we really need to start thinking about the social determinants of health, right? What about housing? What about unemployment? What about food? What about violence, intimate partner violence? Really building programs that address all these different needs. And I think this is something that like Shri Alok Saxena really has been pushing us and has led us to that integration with the Ministry of Social Justice and Empowerment. I think it's also something that Ms. Sangeeta Patel keeps forcing us to do, is work with the other USAID partners. And it's something we're trying to do, is like, how do we actually leverage JAPIGO's, like the health and wellness centers? How do we leverage someone else's TB program to really bring all these different components together to address the whole person? And as new things come, we really need to figure out how do we use them in these markets. For example, long-acting antiretroviral therapy, long-acting MOUD, long-acting PrEP. Like, are these a good fit for India? Can they work? Can they not work? So really trying to figure all that out. It's not an easy thing to do. It's going to be very challenging. And that's what I want to end with a quote from a paper that Shri Alok Saxena and I actually authored for the Lancet Global Health, which actually says such an approach will require an immense amount of political commitment and inter-program and inter-ministerial coordination, but it is something that the country greatly needs. Thank you.
Thank you so much, Dr. Sunil. I will quickly invite Ms. Dia Gautam, who is one of our star virtual outreach workers from Save Zindagi, to come and felicitate Dr. Sunil Solomon. Please. Big hand for Dr. Sunil as well. Thank you. So I should also share that what Sunil presented does give a very fair picture of the work that we've been doing, but I would also encourage you to stay on for all the detailed sessions. I'm sorry, Sunil, I disagree with you there. So I insist. Anyway, thank you so much. Again, we're very fortunate to have with us our next speaker. So Ms. Sangeeta Patel is the Director for Health with USAID. She heads the overall health portfolio with USAID. She's coming in straight from the airport. So thank you so much for being here. A big hand for Ms. Sangeeta Patel, please. Ma'am, over to you for your address, please.
Thank you so much. It really is an honor to be here with you today, and it's exciting. I know that Dr. Sunil and really the entire GHU Accelerate team, every time I come to any of your events, I'm always energized because I know that you're continually thinking of what more can be done and what more we need to do together. And I'm actually honored today on behalf of the U.S. Agency for International Development to be here. I was late this morning because I came back from Hyderabad and I was able to see my friends at the Mitra Clinic and actually see their work in action and really truly appreciate, the launch not only of PrEP, but also of the incredible work being done on the ground and the amount of support that's provided with dignity to allow people to access, prevention, care, treatment, and support services. It is that entire continuum. And I think that for me, at least with USAID, we have certainly been just incredibly grateful, not only for the partnership, but really for the ability to work together and to really think through how we can continue to challenge and learn. And I think that's why we're here today, really, is to say, okay, we know where we need to go, particularly with HIV/AIDS in India. Thanks to the leadership of the government of India, particularly through the National AIDS Control Organization, we've had at least renewed, focus, especially with the launch of the National Strategic Plan for HIV/AIDS and sexually transmitted infections from 2017 to 2024, but also, of course, the NACPV strategy. I mean, all of this for us has been about people, right? It's been about people living with HIV/AIDS and trying to ensure that not only they have access to treatment and that there is viral suppression, but that we also prevent new HIV infections from occurring. And it's not just from a clinical perspective, it's from actually being able to reach the most vulnerable and say, we care about you. And we care not just from the perspective of a disease or an illness, but from strengths, from being able to understand that we're all important contributors in a community and in society. And it's only when we look past the disease and we look at the vulnerabilities and what we're going to do to really look at that societal, social, cultural context and be able to consider those factors really to work together and ultimately to allow people to have greater ages and greater control over their lives. So for me, this program has been far more than just HIV/AIDS. It's been about trying to improve that equity, that access, and really being a model. Just as you heard about some of the work presented by Dr. Sunil, whether it's through the Lancet or frankly speaking through national HIV/AIDS conferences, or even in the approach in India, where we're working through, not only through clinics such as the Mitra Clinic, but even with the government itself. We're learning whether it's multimodal dispensing or whether it is thinking about PrEP or whether it is finding new ways to integrate at the lowest level, whether it's primary healthcare centers and Ayushman Bharat or TB and the National TB Elimination Program. There are so many different ways that we can be working together to really ultimately challenge ourselves and say, we've gotten so far, but we have far more to go. And we can't get complacent. We have to learn. We have to learn what's working, what's not. And frankly speaking, it's this partnership with the National AIDS Control Program that's really allowing us to challenge ourselves, to look at cost efficiencies, to look at not just what we're testing, but asking, hey, what can we do together? What can you do even moving forward? What can we do with the private sector? Because Dr. Sunil's right. You have to look at where people are going or where they're not going and how you can ultimately be able to reach them. And I think this is the divide that this program has been trying to accelerate and actually bridge the gap for. And I think that's why we are such a proud partner here today, not only in this endeavor moving forward, but also in striving to really find what we can do, especially to consider given the multitude of challenges, whether it's, now it was COVID, in the future it'll be climate change, it'll be some other pandemic. We just have to consider how with these multiple challenges, how we're going to continue to work together, especially in that multidisciplinary manner across multiple ministries and across multiple sectors, really to transform and to be able to support change. For me, at least, I think that India's making incredible strides. And I think that we're learning, whether it's the Mitra Clinic in Hyderabad or whether it's through the National AIDS Control Organization as well, really taking a lot of these activities and thinking about how they can integrate even not only at that specific site, but across multiple sites. So really a huge thank you for this partnership, but for being critical with us in challenging us to continue to improve. That's why we're here today. And I'm looking forward, I will say, I am looking forward to hearing about what we've done and what more we still need to do, because there's a lot more we need to explore in depth. So what I'd leave you with, for me at least, is just to be able to say that we're excited and we certainly want to be able to continue, especially as we move forward in looking at what more we can do, especially when it comes to that continuum, but also in looking at if there are other ways that we need to, from that paradigm of prevention, care, treatment, even of being able to look at the private sector, look at other approaches, consider innovation. What can we do to bridge that gap? And what can we do even today to listen and actually think about what more needs to be done? I think you've got all the incredible leaders here in this space with an open heart and mind. And it's because we're not just looking at this as, a disease. We're looking at this as trying to be able to meet the most vulnerable where they are, and trying to improve not only our ability to transform lives, but also to be able to ultimately reach adolescents, reach, our peers, reach people living with HIV/AIDS, look at integrative solutions, and really consider what we haven't done. So thank you so much. It's an honor to be here from the Usaid family to yours, and looking forward to hearing more. Thank you.
Thank you so much, ma'am. I will request Dr. Jalpa Thakkar, who's Program Director with Accelerate, to please felicitate Madam Sangeeta Patel. A big hand for Madam Sangeeta Patel as well. So I also just want to take an extra minute to just acknowledge within USAID as well, some of the support that we receive at a strategic level, people who help us, who help to create an enabling environment for a program like Accelerate, sometimes not really being at the, in terms representing what we do, but really helping us with a lot of it. And Madam Sangeeta Patel is one of them. I'd also like to acknowledge and thank Ms. Vandana Stapleton, who's Deputy Director for HIV and TB at USAID Health Office. And I will request Simran Bharucha, Director for Transgender Health, to also felicitate Madam Vandana Stapleton. Vandana ji, thank you so much. I know I'm catching you out of the blue. So thank you so much. I will now welcome, again, we are extremely fortunate to have Ms. Nidhi Kesarwani, who's Director with NACO. Madam Kesarwani, she has been, she's familiar with HIV work before NACO as well. She's also been the Project Director for Manipur SACS and has held several distinguished positions in the government of India. So I'd welcome Madam Nidhi Kesarwani, please.
Thank you. Respected Alok Sir, ASN DG NACO, Hekali ma'am, our Additional Secretary from Ministry of Health and Family Welfare, all the dignitaries on the dais, all the dignitaries of the dais, and our distinguished community members. Thank you for giving me this opportunity. In fact, it is my pleasure today that to be here at this national symposium, which is being organized by USAID through JHU under Project Accelerate. I understand as in the presentation that this is the 4th year of the Project Accelerate, and a lot of things has been done. What I was heartening to see is that finally we have started shifting our focus from the disease to the person. That is where is the key change. Today, when even in the ministry, we are talking about wellness as a whole package of services which we want to deliver it to our people. And we start seeing we don't focus just on the disease, but overall management of the health, so that an individual has the right to better living, better healthcare facilities, and better nutrition, and various other services which add on to leading a productive and a healthy life. So this is something which I could see, and all the aspects have been covered, and how the synergies have been built. We do talk about breaking the silos and building the synergies, as is the mantra now for NACP 5 within the various ministries, various departments. But yes, there is also a requirement today that such type of synergies are built within the ministry itself, various divisions, various program, where disease program controls where is going on, whether it is with TB or with hepatitis, or it is with malaria or NCDs or any other sort of disease. So that is something which such type of the projects like the Project Accelerate is a very good platform when it comes to for NACP, that we can roll out something, and the new ideas and the innovations can take place, and we work out a system and understand what works and what won't work. and how we can scale these type of these interventions at a national level in a sustainable way, so that with the limited resources which are available in any government sector. So we do know that under NACP, the successes of all the NACP programs is basically in the core of it is the community. Everything is led by the community. It is for the community. And that is how all the interventions are structured and the programs are laid out. So these partnerships are something which should take up further under NACP 5. And COVID has been one of when the COVID issues and during the learnings of the COVID has been seen, one of the best learning is that when it comes to virus, we cannot be complacent at all. And virus has a tendency to come back in some form or the other and affect our day-to-day lives. So though the prevalence rate in our country is just 0.21%, but India as a geography is like multiple countries in one. And we just can't go by the prevalence rate. There are absolute numbers to see. There are concentrations and the pockets to be seen. The change in the epidemic profile and the demographies have to be seen, and how the target groups are getting changed. The prevalence rate amongst various target groups in various geographies are playing their role in the continuation or the propagation of this disease is something which we really have to keep keep in our minds whenever we devise this program. So I'm happy that the learnings, another learning from the pandemic has been that how community interventions have to come when they come together, and we take hold of such requirements of the person as such. How a drastic change within the given program can be taken up, so that the maximum output and maximum service delivery can be given to the target audience. So that is something which I hope that we do have a long way to go ahead when we come to the SDG targets to be achieved, whether it is first 95. I'm happy that the model, especially in the virtual intervention part and how the retention part, the models that has been worked and the SOPs which has been devised are something which really we have to take up and take our learnings from there and cues from there, how we can improve the first 95, which is one of the major challenges that we have as of now, and how we can ensure retention within our services, within the facilities that we have, so that the services can be extended to our PLHIV for various other disease profiles as well, and they are retained and the adherence is ensured by the system, by the government systems and various other ways and means. So I'm happy to be a part of today's workshop, and we hope that such type of newer ideas and the proof of concepts will continue to generate together, and for this program to take up and be a leading success as it has always been in the past. Thank you so much.
Thank you so much, ma'am. I will invite Dr. Subhash Chandra Ghosh. He is the project lead with Accelerate to please felicitate Madam Nidhi Kesarwani. A big hand for ma'am, please. So up next, I think some of you may think we're being clever because we factored in a sub-event with the main event, but it will be quick. So as Sunil shared, we have been working with the transgender community on the Mitra clinics, exploring different models, but we are extremely lucky that through a partnership with the district health authorities and the government in Telangana, we are now able to also provide such services or referrals that are community friendly through the district hospitals. So I will now again invite Dr. Sunil Solomon to the podium for our next feature, which is the launch of the initiation of our help desk, Karimnagar.
Thank you, Aditya. So I'll be very brief this time. I think most of you know the Mitra Clinic model really is a lot of, it is resource intensive and it's very hard to replicate. But at the same time, I think we don't need multiple clinic models. You can have one model with these hubs, which are these help desks. And that's what we really want to launch today. So this is in collaboration with Telangana State AIDS Control Society. So we will be starting a help desk at the Karimnagar facility. So what this help desk is supposed to do is it's within a public sector facility. It provides the trans community with an opportunity to come to the help desk, get access to gender affirming hormone therapy, get access to social entitlement schemes. So we really help them navigate the health system so they get all their different services. And when required, we've established external referrals so they can actually go outside and get whatever additional services they want that are currently not available in these public sector facilities. So with that being said, I think we've decided to be even more innovative and even a little bit cheesy by trying to do a virtual ribbon cutting. So now we've been trying to get the DG to come and do a ribbon cutting at one of our Mitra clinics ever since we started. We have gone through 5. We couldn't make it happen. And so I want to invite sir to do a virtual ribbon cutting. Yes, sir. So you let her come here, sir. Right there? We'll cut it there, sir.
In our hospital, we started the help desk for EG community. With this help desk, we can give better health treatment to EG community. Also, along with all other health problems, including HIV, AIDS, and STI, also we are giving better treatment in a friendly environment. We are like a role model to other districts also. We want to keep in all other districts also help desk for TG community. Thank you.
This is the window where people will be interacting with the clients. Here will be the space, a table, 2 chairs, and few chairs for the clients would be kept over here where they would be interacting with the clients. On the top, we have specialized movement instructions. We have pediatric care. Now we will be also having for general medicines and other requirements for transgender people.
Thank you so much, sir and ma'am, for helping us to inaugurate such a groundbreaking site for the transgender community in Karimnagar. For the as a concluding part to the inaugural session, I will now invite Shri Alok Saxena, who is the Additional Secretary and Director General of NACO, who has again been a guiding light for Accelerate, but of course for many other programs as well. And again, a lot of the work that we do is actually informed and under the direct oversight of Sir as well. So I'll invite Alok Saxena ji for his keynote address, please.
Good morning, friends. On the dais, Additional Secretary Vikali Zimomi, my colleague Nidhi, Dr. Sunil, all other dignitaries on the dais and off the dais, and a whole lot of friends, colleagues, partners. Your mention lights up my face, you know. At the outset, apologies for delaying this by half an hour, and the second apology for having a real bad throat. So we'll bear with it. I don't know whether I'll be able to complete what has been given to me by the usual suspects, but I'll start nonetheless. This National Symposium that Accelerate is organizing today has been, in the works for long. Deepika, Dr. Sunil, Aditya, and Nidhi, we have put our head together that what we should do. As you know, this Accelerate was started around this time in 2019. Can I have water, warm water, please? So in 2019, and we had, a lot of energy, time, and thought had gone into it. And we thought with our PEPFAR partners in the US mission, we had a lot of discussions with them. We wanted it to be groundbreaking. We wanted it actually to implement the vision that we had of how partner-supported works should integrate with the program and how they should help and take it further and create sustainable models. So a whole lot of thought had got into it, but unfortunately, as you know, I think it was the third month, Dr. Sunil, or second month, when the pandemic actually showed itself globally. So a lot of things that were planned went awry. A lot of new things which we never thought will be there, we implemented them. We learned on the way together. But what could not be done in a very systematic manner, which earlier we were doing with other partner-supported projects, was disseminating, talking about it, taking the learnings further. So because the very nature of PEPFAR supported programs is that it is concentrated in a few districts in 3 states. So how do we disseminate that good work? Because our mantra, even when we were designing Accelerate, was, and prior to that, I have my friend Bitra sitting there, hi, for the predecessor linkages, that, this is, as I always say, the amount that comes under PEPFAR, that's of course significant, but more than that, it is the thought behind it. It is, as I always say, American taxpayers' money. So we have to spend it as we spend our own government's money. So 1, 2, it has to lead us to models which are needed, which normally you cannot do, but which create sustainable, economical, various models that can be replicated elsewhere. Now, how do you do that if you're doing it in 5 districts in one state and 2 districts in another state? That you have such dissemination events. Another learning of the COVID pandemic has been that everyone need not be in a room. You can have a virtual or a hybrid meeting. Though personally, I don't believe in virtual meetings because, as people say that. So you also don't believe in that. Obviously, Vivek will not believe. He would like to feel his tomatoes, isn't it? So that's what your guru tells you. So now, but the energy in this room, that is palpable, that is infectious, and that leads us to think, that leads us to forge cooperation and partnership and friendships. So that's important. So maybe, but till such time that we have this mutant ninjas coming one after the other, we can have virtual or hybrid meetings, but it's important that dissemination is done. So that way, this event is extremely welcome, Deepika, Vandana, and Sunil, and Sukhwinder, that we are doing it, and we need to do it more often. Talk about it, showcase the things that we have done, learn from others, take ideas from others. So that was the first thing that we wanted to do. Also, when Deepika came and we were designing, I said, put as many things as possible, including things that we did earlier when Bitra was there, because after all, the grand challenge we took, that let's push things that other people can do. So they've been very gracious in that. The other point is that in AIDS control program, partnership is very important, because alone we cannot do. As I always say, I'll repeat it again, that this is a program where the disease, if we come to first, disease, the primary route of infection still remains sexual route. In India, there is, if I use the word shame attached to sex. So we don't talk about it. We brush it under the carpet. And if there's a disease coming out of that, then it's a huge embarrassment. So we would not like to talk. There are very few people left in this room today who are of my age. But when we were young, and there was one time when I was young, so there were these government-supported condoms ads. The Nirodh ads used to come on television, and everyone would look the other way as if it doesn't exist, So that's how we, what I'm trying to say, that's how we, handle these things in the past. But it's important in this program, we have been able to normalize the talk about condoms, the talk about sex, the talk about, homosexuality. So here you see anything that, our key populations are, or anything we do is linked to that. So whether it is the sex workers or the MSM or the transgender people or even drug abuse, injecting drugs particularly, all that falls on the other side of law. So it is only through partners that we can work in these areas effectively. We can take the service delivery in those areas. We can get the feedback back from those areas, and we can further perfect it. It's a constant exercise. So this is how we started. Then in 2004, when we started dispensing under the program ARV drugs, gradually in 13 years, we were in 2017 at Test and Treat, where everyone who was tested positive is to be put on treatment. So today we have almost 1.5 million people on treatment. So as a result, you have a cohort of people living with HIV and their families, and that number, which is a substantial number. So they are another set of partners we have. They bring another corpus of wisdom for us. So that is something we need to tap into. We've been doing that, and as Sunil was showcasing, TAL is one such initiative which brings the strength, the vibrancy, and the wisdom of the networks of people living with HIV. So thank you. Yeah. So this is something that we are doing. Partners bring that additional outside or extra perspective to it. So far, it's been so good. Also, there have been setbacks on account of the COVID pandemic. But there are 2-3 things, a lot of things that you've shown, and we are doing it. Sunil has been honest enough to accept that certain interventions are investment intensive and hard to replicate. So how such interventions, A, should be made lightweight in terms of investments and HR, and B, replicable. So that's a challenge that remains. Maybe virtually linking them, like we have inaugurated the helpline today. That's one way. The other way is that we give it to the partners, or we give it to the communities. We like TAL has been done, that unse kahiye wo kare. Let them do that. Also, this is for Manoj, and of course, TAL you're running, is that when we're doing any such initiative, we need to be, and not just Manoj, Manoj is my friend, that's why I'm naming him, it could be anyone, that, when you tick all the boxes, that is important. That if for dispensing drugs, you have to have a qualified pharmacist on the other side of the counter, you need to have, aap community se laiye, lekin lekar aiye. That's important, because all those regulatory boxes need to be ticked, So, I mean, we have in the Mitra clinic, our Dr. Saab is from the community, the entire thing is, everyone is from the community. So that's something that is doable. Maybe a little extra effort is required, but that's something that's really required. The other thing that we need to do is also talk about and work in the direction of STIs. If we in NACO, under the NACP, we don't do it, nobody else will do it. Hikali, it's important. It's an agenda that we have before us, that a lot of work is getting done in HIV/AIDS, but STIs also is NACO's sole mandate. Nobody else will do it. So while we talk about TB, and we have done, because that's a primary comorbidity, we also want that we should work closely with viral hepatitis, because the root is same and the treatment and the structure of service delivery is same. But STIs, nobody will do it if we don't do it. We need to take that as a priority. We have been doing it. But in the routine of running a humongous program with so many people sitting in New Delhi, in Chandralok, sometimes we lose our focus. It's important that partners, that communities come back and remind us that ये आपका एक challenge है और ये आपको करना है. So we need to do that. Also, Sunil has, and USAID and PEPFAR leadership have been very helpful and accommodative in that we have requested them to take it to other geographies where it is needed. Because there's certain thing that you cannot do in Mumbai or Maharashtra or in Hyderabad. And that kind of activity is happening in central Uttar Pradesh, from where, Hikali comes, and that's her strength. That, Unnao for some of you is a word, but for Hikali and I, we've worked there. So we know what it is, or Kanpur or Raebareli or Lucknow. So that's something, that focus we need to bring. Similarly, Delhi, which they're doing, both in PWIDs, HIV/AIDS, but also in STIs. So that we need to do. We need to, with a messianic zeal, work for dual testing. That's important, because one thing, in one draw of blood or drop, you can have both the tests for diseases. So that we need to do. That's something we can do. Why I'm talking, though of course these are programs, priorities, and enshrined in NACP 5, but why I'm talking here is that let's think, can we have new models to arrive there, to reach there? So that was the other thing I wanted to say. And lastly, I would say that this partnership that we have with our American partners, USAID, PEPFAR, CDC, that has been extremely helpful and extremely focused in bringing certain ideas to the fore. We need to work there with more focus. I've also briefed Hikali about OVC, which again, Vandana needs some more push because that's something that is required, but we occasionally, both NACO and PEPFAR, lose focus on that. So perhaps we need to have a relook at OVC program. Deepika particularly usko dekhiye that how we bring the focus back. Now there are post-COVID pandemic, there are more services available in other departments or by the state governments themselves for children, for support program for orphan in terms of pension, in terms of education, in terms of loans, how we can link them, and we can make that something of a showcase under this particular project. So with these words, I thank everyone in this room for coming on a Saturday. And I also thank Johns Hopkins, Accelerate Project, US Mission, PEPFAR, USAID, and all our partners to be here. Thank you very much.
Thank you so much, sir. I will invite Dr. Sunil Solomon to please felicitate Shri Alok Saxena ji. We expect a much bigger hand than usual. Also, I will just quickly request Mr. Sri Krishnan, who is the CEO of YRG Care, to please come and felicitate Madam Hikali Zimomi, Additional Secretary, Health, Ministry of Health and Family Welfare. A big hand for ma'am for being here today. So Finally, for closing the inaugural, I invite Ms. Deepika Joshi, who is the chief of the HIV/AIDS division in Usaid, India. Please welcome Deepika Joshi.
Thank you very much, Aditya. A very good morning to all of you, all our dignitaries on the dais and off the dais, dear colleagues and friends. A wise person once said, a grateful heart is a magnet for miracles. And so I feel honored to stand here today with the proud privilege of giving a vote of thanks for this inaugural session, because the more we are grateful for what we have, the more of it we will get. I want to start by thanking Shri Alok Saxena, Additional Secretary and Director General, NACO, for his untiring commitment to public service. And I will take the liberty to share a personal experience to elucidate this point. So when I approached you to discuss the organization of this event and the rationale behind it, I said to you that you have been at the helm of affairs, envisioning, guiding, steering so many path-breaking innovations under this project, and that we would be honored to have you lead this event that shares all the learnings to fuel further thought and action for adaptation to the larger country context under NACP 5. And you responded, and I quote, Deepika, let's discuss this idea further to have an event not as much as regarding my time at NACO, but what we can achieve in the future based on our actions of the past few years. I'm sure all the teamwork and efforts that have been put in will bear fruit. And that has been the hallmark of our program, which distinguishes it from any other public health program anywhere in the world, end quote. I don't think I need to say more. It is this very attitude that has enabled the program to tread the path less trodden and reap unprecedented results. Thank you, sir, for inspiring us to dream more, learn more, do more, and become more. And we hope to continue with the same fervor and enthusiasm under the dynamic leadership of Ms. Hekali, who's incoming in just a few days. So we're very much looking forward to that opportunity. I want to extend a heartfelt thanks to Ms. Nidhi Kesarwani, who I've observed to be a resolute leader, who's constantly listening and gauging the impediments to success, while devising innovative solutions to overcome those challenges. Ma'am, my sincere hope is that under your leadership, we will be able to bring all our lessons in adopting accelerates human-centered approaches to drive epidemic control to inform NACP 5. Ms. Sangeeta Patel, for those of you who know her, know that leading USAID's multi-million-dollar public health response is not a job that she performs, but it's a cause that she espouses. Sangeeta is a true example of a bold and unconventional leader who constantly inspires her team to think out of the box. Thank you, Sangeeta, for being a fervent advocate for the voiceless and a visionary par excellence. Sunil, thank you not just for bringing cutting-edge science to this project, but more so for the passion that you bring to this work. We know that working on HIV epidemic control is not just a professional goal for you, but rather a personal calling. Taking forward the inimitable legacy of your parents, especially the legendary Dr. Sunil Solomon, you and your team have generated robust scientific evidence with program learnings that we are all learning from. Your exceptional team is translating USAID's vision into reality. And for that, I thank you and the entire Accelerate team, including YRG Care, Fenway Institute, Blue Lotus Advisory, and the numerous local champions that you partner with on a daily basis. Last, but certainly not the least, I want to use this privilege to thank every single one of you present here today, and even those that are not present in this room. PEPFAR, our STAR team at USAID Health Office, all the support offices, including my stellar HIV team, Sukhwinder, Rita, ably led by Vandana Stapleton. The dynamic SACS leadership, the DAPQs are, I don't know how to refer to them. Well, I'll call them the people that actually make the Adidas tagline, impossible is nothing, seem very real. The NACO dream team that works day in and day out for this program. And I see all of these faces here. I see Vinita, I see all the HODs, I see all these dynamic people who I have learned from on a daily basis. Thank you so much for what you do. Our multilaterals, UNAIDS, WHO, GFATM, our partner collaborators, implementers, researchers, and most of all, our communities. You are our ikigai. You give our lives a meaning and purpose that powers us to persevere. You are the wind beneath our wings. I thank you all of you for being here today to absorb, to contemplate, to share, and to learn. With this, I conclude this vote of thanks. Thank you very much. Namaste.
Thank you so much, Deepika. I will request Dr. Partha Sarthi, who is Deputy Director with Accelerate, to please felicitate Deepika.